Well, this is actually the outcome of a few patients, which is like a pilot study for locally advanced unresectable pancreatic cancer, in which we try to use hypothermia along with the chemoradiotherapy. So I just want to share some of the things that we observed by adding hypothermia to this group of patients. Actually, if we look at the problem of pancreatic cancer, especially in Europe, it's actually the fourth cause of cancer of death in Europe. And it's estimated that 98% of the life is actually lost because of this cancer. With just a median survival of just about 4.6 months and a median 5-year survival of just 3%. And this is the data I'm sharing from Europe only. So certainly it's not a very good disease for our patients to have. And it's also said that if cancer is the emperor of all maladies, then pancreatic cancer is the ruthless dictator of all cancer. So certainly it needs that we have to change our approach, try to see if there is something else which could be offered to these patients. And that's one of the reasons that this particular approach has been tried. And we currently have an ongoing trial, which is the HEAT-PAC, which is a phase 2 randomized trial between concurrent hypothermia and chemoradiotherapy versus chemo-RT in these locally advanced pancreatic cancers. So what we have here is in the HEAT-PAC study, it is the pancreatic cancer which are tumors more than 4 centimeter. They are all subjected to FOLFIRINOX 4 cycles neoadjuvantly, and then concurrent gemcitabine, radiotherapy, and hypothermia. The rationale for this approach is that we won't like to take the advantage of radiosensitization by hypothermia, radiosensitization by gemcitabine, and also it has been shown that hypothermia actually potentiates the action of gemcitabine if it's preceded by 24 hours. So in fact, what we are trying to work upon is a triple sensitization. The HEAT-PAC study actually consists of, as I said, 4 cycles of neoadjuvant chemotherapy with FOLFIRINOX, reassessed with PET CTs, and then randomize the patient either into a control arm of CT-RT or into a study arm in which hypothermia is added to the chemo-RT, and then follow them with FOLFIRINOX another 8 cycles and follow with PET and CT. So while we are actually conducting the study, so this is how we would like our patients to go on. So we have the hypothermia starting on a Monday with the radiotherapy for 5 days a week, and then gemcitabine comes on actually day 2. So that's hypothermia, radiotherapy, and gemcitabine. So while we were actually working on this protocol, we thought of trying to have some patients whom we could just assess that if they can go through the entire course of the treatment. And also while the protocol is being on, there were some patients, especially with an M1 disease, who are not actually taken for HEAT-PAC, but they had just single isolated lung metastasis or so. So we thought that, okay, we can treat them and try to see what happens when they put them on a chemo-RT hypothermic protocol. So these are selections from these type of patients. So the pre-assessment was in the same way: histopathology, hematology, serum biochemistry, radiology, using a PET CT or an MRI or both. And then on post-treatment, they were checked on a PET CT with or without MRI. The response was evaluated using the RECIST criteria and the toxicity by CTCA 4.03. So this is the 8 patients. The follow-up stands between 2 to 19 months. And as you can see that there were 2 patients who had an M1 disease, and certainly they are not the patients whom we could have taken for the HEAT-PAC protocol. So all these patients received FOLFIRINOX, median cycle of 4, followed by gemcitabine weekly, median cycles of 6, with a CYP-IMRT with a clinical target volume dose 50.4 and a GTB of 56 gray, and then followed by post-CT-RT FOLFIRINOX of a median of 8 cycles. So there we started with a CT scan for hypothermia planning, did the planning in the usual way using segmentations, using hyperplan. And then for temperature measurement, since it was not feasible for us to put the temperature probe within the pancreas, so that we thought the best possible way was to endoscopically place the temperature probe before every hypothermia treatment sessions. So we had to wheel in the patients to the endoscopist to put the temperature probe, and then we used to check it on a CT scan and verify the check positions, and then take the patient for direct hypothermia. So that's how the 8 temperature sensors, which actually covered a length about 14 centimeters, and we took care that the temperature probes are lying encircling the duodenum, so the entire pancreas is actually encircled by the temperature probes. So here you have the hypothermia, radiotherapy, and that's the one of the patient's outcome, the pre-treatments. You see on a PET positivity, even after 4 cycles of FOLFIRINOX, the disease is still metabolic active. But at the end of hypothermia and chemotherapy, at the end of 3 months of the treatment, you have a negative PET CT. Similarly, there's another patient here, pre-treatment PET CT. 4 cycles of FOLFIRINOX, the disease metabolically still active. 1 month, you have a metabolical CR, and finally, even at 12 months, the patient is metabolically CR. So as I said, the follow-up of these patients is about 2 to 19 months ranging, and here we see the progression-free survival. There were only 3 patients who actually progressed, so the progression-free survival is about 62.5%, with a median progression survival of 19 months, and 1-year PFS was about 60% for these patients. And if we look at the survival, well, we lost 2 patients, and the median overall survival for this group was 15 months, which is quite encouraging compared to the usual value that we see of 3.2 months, and a 1-year survival of 80%. So based on this, we also saw that the treatment compliance was quite well tolerated, and there was no acute grade 3 or 4 toxicities in any of these patients, along with the chemotherapy, both as a neoadjuvant and also after the treatment. So just to conclude, it appears that hypothermia added to the chemotherapy, as we have been using, is safe and feasible for these type of patients. Early results are certainly encouraging, both in terms of the progression-free survival and the overall survival, and this should certainly facilitate the recruitment of the patient for the ongoing phase 2 randomized trials between CTRT versus CTRT HT. Thank you very much.
Thank you. Any questions for Professor Datta? Yes, Professor Woost.
So probably you have decided that all pancreatic cancers are non-resectable, or
No.
Is there
No.
after
Certainly not.
After FOLFIRINOX?
Certainly not. The treatment of choice for
when do you look again?
Sorry?
You look again after 6 cycles FOLFIRINOX for surgery, or?
As for the protocol is concerned, the decision of locally advanced pancreatic cancer is taken at the time the patient comes for the first contact.
Okay. So there is no restating
with the pancreatic board.
After.
The PET CT is done after 4 cycles of FOLFIRINOX to make sure that the patient has not progressed a disease in the peritoneal cavity, so that if the patient has even a microscopic disease, in the peritoneum, then these patients can't
Have
be
you
taken
found
out.
some patients which you have excluded because of?
No, what you mean perhaps is that those patients who has a significant downstaging and then should have been excluded. No, that's not as per the protocol.
Or have metastasis after FOLFIRINOX?
Yeah, if they have a metastasis, then certainly
Yes.
they can't be
And
taken.
how
because-
many do you found some
No,
patients?
these are all the pilot patients. I'm not showing you the
There
results
has
of the
no
heat pack.
patient had metastasis after FOLFIRINOX. of the 8 patients?
No.
Okay. So
There were 2 patients who already had a metastasis in the lung, so that is why they were not taken for the heat pack,
okay.
but not a peritoneal.
After FOLFIRINOX, they had metastasis in the lung.
Prior to FOLFIRINOX, they already had.
Before.
They-
Okay.
yeah,
then
they already
then
had.
you have excluded them.
Yeah.
Okay, that's clear.
Well, I know FOLFIRINOX from our German Conco 07 study. And we know that about 1/3 of the patients who get FOLFIRINOX will get metastasis during FOLFIRINOX in the liver and not in the lung. And we know that about 20% of the patients get resectable, even if they are unresectable at the beginning and can be completely resected following FOLFIRINOX. And these patients have a very good overall survival. Therefore, I would advise you to do a second evaluation following FOLFIRINOX to select these patients who are getting resectable. This is about 20% of the patients.
Well, yes, certainly we do believe that there would be some patients who would have a good downstaging of the tumor. But as I said, this entire protocol was discussed multiple times, I think over 3 years, with our surgical colleagues at the University Hospital Zurich, with the medical oncologist, and it was a basically collective decision to follow it in this way. So at this point, since the protocol is already ongoing, so I don't think it's possible to change until we find really something drastic.
Then Dr. Veselovsky, if anyone has any other questions, yeah?
And do you include only locally advanced, completely irresectable, or borderline resectable?
Unresectable, totally
Only
unresectable,
totally unresectable.
not even borderline. These are totally unresectable.